Hello, my name is Alejandro Tell, and today I'm going to talk about ultrasound guidance for pleural catheter placement. So let's start with definition. Ultrasound guidance is currently considered to be the safest means of positioning a pleural catheter and draining a pleural effusion. This technique requires the development of skill in the use of ultrasonography and in catheter placement. Applications in medicine. In ultrasound-guided pleural catheter placement, no skin marker should be used, since it may interfere with sepsis. Also, the parietal pleura should be punctured with the use of a pointed stylet to reduce trauma. Finally, stepwise pleural drainage is mandatory to avoid expansion of pulmonary edema.
Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at the New York Presbyterian Hospital in New York City. And welcome to Soundbites Cases. In this Soundbites module, I'd like to begin by discussing the case of a patient who presented with worsening shortness of breath and had a chest x-ray which revealed this finding. Notice here we have the presence of an opacified left hemithorax, and notice here that the trachea is pushed away from the left hemithorax, suggesting the presence of a very large pleural effusion as the cause of our patient's dyspnea. Now, if in fact this was a large pleural effusion causing our patient's shortness of breath, a therapeutic thoracentesis would be in order to relieve her symptoms. This leads into the topic for this Soundbites module, which is the use of bedside ultrasound to perform the thoracentesis procedure. In this module, I'd like to go through how sonography can potentially make the thoracentesis procedure a safer one for our patients with a decrease in the inherent complications of the procedure, such as pneumothorax or perforation of the diaphragm. Before performance of a thoracentesis procedure, it's mandatory to look with sonography to make sure that there's enough pleural fluid amenable for a safe thoracentesis. Notice here we have the patient positioned in an upright position so that the fluid will layer out above the level of the diaphragm. Notice here we note the diaphragm as shown by the red line across the patient's anterior chest wall. Notice here we have the probe positioned along the lateral aspect of the patient's chest with a marker dot towards the patient's head. We can angle the probe above the diaphragm to look for a dark or anechoic collection of fluid consistent with a pleural effusion. This is the
Pros and cons. Pros. On the basis of our experience with more than 5,400 ultrasound-guided pleural catheter placements over the past 10 years, we highly recommend a different approach. Cons. In ultrasound-guided pleural catheter placement, no skin marker should be used, as I said before, since it might interfere with the sepsis. Local anesthesia should be applied with the use of ultrasound guidance to precisely anesthetize the skin on the parietal pleura.
A phased array transducer with an abdomen exam type is used to evaluate the chest cavity for the presence of fluid. The procedure is best performed with the subject in a sitting position, leaning slightly forward to allow access to the posterior chest cavity. The patient is instructed to breathe normally, and the transducer is placed in a long axis orientation over the posterior chest wall at the 8th or 9th intercostal space in the posterior axillary line. The orientation marker is directed to the patient's head. The ribs are identified in the near field of the image as a bright interface with the posterior shadow. The pleural line is identified as a bright hyperechoic line between the rib shadows. The to and fro sliding movement of the visceral pleura against the parietal pleura with breathing generates the lung sliding sign. The transducer is moved along the posterior axillary line to identify the bright hyperreflective diaphragm. Fluid will appear as a dark anechoic area in the dependent area of the chest cavity. Identify the borders of the fluid collection and the normal appearing lung. A needle insertion site should be chosen in the posterior chest in a dependent area of the fluid collection. Adjust the transducer so it is located between two ribs. The needle should be inserted just below the center position of the transducer to allow the needle to pass just superior to the lower rib to avoid the neurovascular bundle which lies on the inferior surface of the rib.
Issue applied in Ecuador. In Ecuador, this technique is performed in more than 500 patients per year, in which almost 90% are satisfied. And conclusions. As I said before, ultrasound guidance is currently considered to be the safest means of positioning a pleural catheter and draining a pleural effusion. This technique requires the development of skill in the use of ultrasonography and in catheter placements, so this is the safest option to help manage the life of these patients. Thank you for your attention.